So really looking at understanding the impact of infertility is really important. We can see from the survey that this has a huge impact on all areas of people's life, but in particular on their mental health. We know that we're talking about a large number of people, 3.5 million people across the UK are affected by infertility, and that generally works out as 1 in 6 couples struggling to become parents, many of whom will not be successful at the end. We know from what people tell us that it's a devastating journey. There's a lot of despair, anxiety, disappointments along the way. But now through the survey that we've carried out, which was carried out by Dr. Nikki Payne at Middlesex University, we have a better insight into this. And the report is now available on our website, and we'll try and get the link into the chat for you so that you can get a link to that and see the whole report. So as I say, 1,300 patients took part, including Northern Ireland patients, and it looked at a number of areas: mental health, finance, careers, relationships, and the information and support they got. But still, very little has improved. Gwenda Burns, our chief executive, has commented in Fertility Week to say, fertility patients encounter a perfect storm. Not being able to have the child you long for is emotionally devastating, but then many fertility patients face a series of other hurdles, as this survey shows. So immediately we could see that 83% felt sad, frustrated, worried often or all the time. And that's pretty much similar to last time. And 47% said they experienced feelings of depression, which is a very high level of concern. The most shocking statistic of all is that 40% of people reported having suicidal feelings. And we know from talking to patients that this is not uncommon, but very largely way above a sort of national average of suicide. 10% of those 40% said they had the feelings all the time. The feelings didn't go away. And even just getting the diagnosis of infertility was enough to make people feel that life just wasn't worth living. And this is something that has affected, we've been in contact with people who felt this way, both women and men. So it can affect both partners. In the relationship as well, 59% reported damage to their relationship as a result of infertility. We know that a small percentage of relationships actually break down through the journey. In terms of seeking help, 51% had counselling. That's only half of the people managed to get counselling. And of that group of people, 59% of that group paid for it themselves. We are lucky here in Northern Ireland that there is provision to fertility counselling, and that we welcome and signpost people to. And we're very lucky with the service that's provided here, but still, perhaps we need more. In terms of the financial burden, 2/3 of people pay for their own treatment. We know that we are in the middle of working with the Department of Health towards the move to additional cycles. We welcome this, but we know that at the moment this still is a postcode lottery right across the UK. Only Scotland, maybe you know, has the gold standard that adheres to NICE guidance, which provides up to 3 cycles of IVF. And that is hopeful for Northern Ireland, that we will work towards that in the forthcoming months. The average cost to a patient who was paying privately of treatment of Vigestia, remember this is an average cost, £13,750. The cost of living squeeze is going to make that even more difficult. And 12% spent over £30,000. In fact, a few people were reported as spending up to £100,000 on treatment. So the chair of British Fertility Society, Dr. Raj Mathur, said for 47% of the survey to report feelings of depression, and as many as 10% report suicidal thoughts, often or all of the time, is unacceptable. And that's me. And I just want to say that I'm really grateful for you to be here. I want to pass over now to Ian, who's going to share one little slide for us, and I will put myself on mute. And if you have any questions about the survey, or you can't access the link, we'll get that sent out to you afterwards. Many thanks.
So with that, let's move on to our first speaker. Our first speaker is Professor Siobhan O'Neill. Siobhan's a Professor of Mental Health Sciences at Ulster University and an internationally recognised scholar in the mental health field. Siobhan has a wide range of research interests with trauma, mental illness and suicidal behaviour in Northern Ireland and the transgenerational transmission of trauma as her main focus. In September 2020, Siobhan was appointed as Mental Health Champion for Northern Ireland, and in that role, her role there is to advise and assist in the promotion of mental health and wellbeing through all Assembly policies and services throughout the province. Her role is a public advocate and to communicate the collective voices of people with lived experience and their families and carers, and to advocate for communities impacted by mental health inequalities. So Siobhan's well placed to give us a policy context to this, and from an academic viewpoint, give us, her understanding of where we're going and the scope of the issue which we're talking about this morning. So Siobhan, over to you.
Good morning, everybody. Good morning, Ian, and thanks so much for the invitation to speak here today. What a pleasure to be able to speak to this group. I'm going to share some slides. Hopefully this side of the technology will work. I think if it works if you do it in this order. So yeah, I'm going to talk about infertility and fertility issues as a trauma. And a wee bit about the Northern Ireland context there too, but also to say that I'm part of this community as well, that I've been through this on many, many occasions. So when I'm talking about this, it's something that's actually very personal to me. And when I go through all the issues, it's still so live. I mean, my situation is that I'm a single parent now with a 5-year-old, so things don't end up the way that you think they're going to end up, but it ended up really well for me. The outcome was really good, but it was a very, very difficult journey. And so let me start by talking just generally about trauma, the characteristics of trauma. So what I'm doing here is kind of building an argument for fertility and infertility treatments, all of this stuff as a trauma, very clearly a trauma actually. So when we talk about trauma, we talk about an emotional response. Now, sometimes there's physical trauma as well, a physical thing that trauma to the body. But in this context, it's an emotional response to an event that is life-threatening. And that's the key thing. It threatens our life or our integrity. And usually in this context, it's about an accident or an attack or a sudden death. Those are the kind of the socially acceptable traumas that we talk about, and those are significant trauma, but infertility is a trauma too, without a shadow of a doubt. Other definitions of trauma talk about physically or emotionally threatening or harmful. So it's our life, our integrity, and when I'm talking about life there in the broadest sense of the word, the life that we wanted, the life that we think we should have, the life that we dreamed of, and our hopes for our life, that's all part of our life. So anything that threatens that, and threatens it so fundamentally as difficulty conceiving or infertility, then that's a trauma without a doubt. So when we talk about trauma and mental health, this is the relevant slide that I use, and it's our circuits of survival. So trauma is a chronic stressor, infertility is a chronic stressor too, and stress impacts our mental health. So our circuits of survival are our body's response to stress and threat. So most of the time we want to be in that safe and social space in the middle where we're calm and engaged and connected and all that stuff. And most of us who are presenting this morning probably aren't in that space. We're in fight or flight. There's a bit of threat, you know, and that's our stress response, but it's our body's way of preparing us to fight or run away. We're mobilized, we get shouty and angry and stressed, and it's our body's way of protecting us and making sure that we survive. But of course, if you have to do a presentation, or if you're trying to get the technology to work, fighting and running away doesn't work. We have to be calm. So we have to get ourselves back into safe and social. And stress is part of life. It's an absolute part of life. But if we're up there in fight or flight too much, that fear response is switched on a lot of the time, then our bodies adjust, of course, and we get that chronic fear, chronic anxiety. And that's the most common mental health problem, is that chronic anxiety. And the things that happen to us across our lives, particularly in childhood, are little triggers that will push us up there. They're wired in, you know, especially in the first few years of life, they're wired in. So that's our fight or flight response. The shutdown response is like the trauma response, the sudden death, and we get some really devastating news, and often people will have had that shutdown, that frozen, that numb response whenever they have that diagnosis, or whenever they realize for the first time that they have difficulty conceiving. But for infertility, a lot of people are in that fight or flight response all the time because it's chronic stress. So we can have various different levels of these. And shutdown, if we're down there too much in that frozen, disconnected state, we can feel suicidal, we can feel hopeless, and frozen and numb and disconnected. Again, it's the body and brain's way of protecting us from the reality of something, that disconnection that happens with the shutdown response. But over time, if we get stuck down there, we have the symptoms of depression, and we start to think in a different way about the world. If we're up in fight or flight all of the time, we can become hypervigilant a lot of the time, where we're easily activated, or we're constantly on the lookout for things that are about to threaten us. And of course, PTSD is a combination of both, and I'll talk about that towards the end as well. But the stress of what we're going through in infertility can push us up into fight or flight, or down into shutdown a lot of the time. In fact, so much that we become stuck in these different states, and we need a bit of help to get back into safe and social, so that we can be calm and we can really live our best lives and problem solve. So mental health, I talk about mental health as being relevant to the trauma continuum, where we have stress at one end, which is necessary, and distress and trauma at the other end. And it's that chronic stress, or the distress of trauma, that leads to biological dysregulation, and that changes how we feel and think and behave. And that's all mental illness really is. It's various different combinations of those things that result from what has happened to us. So I normally talk about stress and trauma, particularly in the context of Northern Ireland, and we've been through a lot of it. And this is from a 2005 study. It was published in 2011. There was a lot of papers came out of this one. It's the World Mental Health Survey Initiative, where we analysed the rates of mental health difficulties and trauma in 30 countries around the world, and I was involved in the Northern Ireland one. It was led by Brendan Bunting, and we found then back in 2005, 2008 that nearly 40% of the population had been exposed to conflict-related trauma, and 18% had seen someone killed or seriously injured, and 39% met the criteria for mental illness. Many of those mental illnesses were mild, and we had high rates of mood disorders and high rates of post-traumatic stress disorder. And at the time when we put out these figures at the start, people didn't believe us. And there were newspaper articles saying that we weren't the most traumatized. We had coped really, really well. In fact, we were very resilient. And when I was thinking about this talk today, I think that's the thing, actually, the similarity between these two situations. Because we don't talk about infertility, there's still that stigma, there's still that sense of shame and isolation, and I can say that because I've been through it. And it's not recognised as a trauma, and that's a problem. And we need to start calling this what it is in order to understand it properly and to make sure that people get the treatments that are needed, and get the support that they need. And, you know, there's an impact on the next generation, and there's an impact on all of society, regardless of the outcome, whether there's children involved or not. There's always an impact. You know, there's always a cost to this. So we'd be as well to start to address it. Thankfully, in Northern Ireland, we are starting to address the mental health consequences of the troubles, and we're recognising now the trauma and the effect of that trauma. And I hope this can happen for fertility issues too, eventually. So what's infertility? What does it mean? What does it look like? These are just some of the thoughts that I had when I was going through it. It's not from any particular research report. It's, you know, it's characterized by difficulty conceiving for whatever reason. You know, in the end, I was a single person, and I wanted a child. So that was my situation. I was a part of a couple at one stage as well, you know, and people who are in same-sex relationships will have this as well. There's a difficulty in having that much longer for a child or a family, that the thing that you wanted in your life, that your expectations for your life. There's often many tests involved. And, you know, very physical tests, and often things that we don't want to talk about or tell other people about because it's deeply personal, it's deeply private. And then there's diagnosis, or maybe even no diagnosis. And that's really difficult as well, if there's this sort of not knowing what it is. And many people have gone through that too, and that's an added layer. And then there's treatment. Or deciding not to have treatment or interventions. And my goodness, that spans from for me, certainly the boxes of vitamins that were coming through the door, and all the diet and the exercise and everything that you did, and the meditations, right through to the interventions, the medical interventions, the hormones, the pills, the injections, all of that stuff. And the whole thing is characterized by loss from the start to the finish, because it's not what you want to be doing at that age. It's not the way that you think your life's going to go. So there's loss straight away, but there's many other losses along the way. Even if the outcome is that you have a child or that you become a parent, there are so many losses, and that extends beyond that because it affects your whole life. Even as a parent, that's always there in the background, and there's things that you need to discuss there too. So that's infertility. And what are the elements then that map onto chronic stress, which causes mental health problems, let there be no doubt, and trauma, which causes complex mental health problems and more complex symptoms. So it's life-threatening in the sense that it does threaten our view of our lives. And many people will feel that a life without a family is not a life that they want to live. And they're questioning that, and they're sometimes feeling suicidal. They're going in and out of suicidal thoughts. They come and they go. And that's the nature of suicidal thoughts. It's not that people feel suicidal all the time, but they can feel really deeply suicidal at particular times. And that's true for infertility as it is for all other situations, other life events that are associated with infertility. And the suicidal thoughts need not accompany a mental illness. They can come as a result of this huge life crisis. So it's not, you know, you can have one without the other, is what I'm saying. And there are different treatments for suicidal thoughts compared with treatments for depression. But it is absolutely life-threatening. It has an impact on your work. So everything that you're doing on a day-to-day basis is impacted by this as well. It's physically painful. Often there's lots of things that you need to tolerate, and investigations and painful things that happen as part of the process, particularly through IVFs. I've had so many of these now, and they are painful every single time. There's pain, there's swelling, so you've got all that on top of everything else at an age, and in addition to any other physical health problems that you might have too. So it's not on its own a lot of the time too. There's also shame. There shouldn't be shame Let me be very, very clear. This is so common. Actually, why would we be ashamed of it? It's absolutely normal, but it's to do with conception and relationships. There's two people involved. So unless both people are on the same page about how we're going to disclose this, then there can be that sense of shame. And it totally affects the relationship there as well. And there's financial pressure. Wow. I mean, I'm talking a lot about the impact of the cost of living crisis on people's mental health, but the financial pressure of this is enormous, you know, and we take on debts in order to do this because it's worth it, you know, but these are gambles in many ways. It's not like buying anything else. And I know there's situations that you can get refunds and all of that stuff, but you're essentially gambling a bit. It can feel like you're gambling. You're taking a risk. You're getting into debt for something that mightn't result in the outcome. And even if it does result in the outcome that you want, then you've got all the childcare bills and everything and paying the whole thing off whilst you're dealing with a child. And it's just so unfair. That whole process is so unfair, and that you're penalised. And so that's why I'm pleased that, you know, we're moving towards those 3 cycles. And the treatments for people and paying for that treatment is so important as well. To take one bit of that, one bit of all of this out, it would really, really help. So the financial pressure's huge, and it has a mental health sequelae all of its own. So, and then there's the shame and the silence and the social isolation. You feel ostracized, to be frank. I felt that this was not a club that I was ever going to be part of, you know, and parents don't do it deliberately, but it hurts so much, and it's not socially acceptable to talk about the hurt and the pain that comes with that looking on, and the triggers are absolutely everywhere, you know. And if we could be more trauma informed about this, even like I try to be, but I know as a parent I'm triggering people as well, because I'm putting up pictures of my child on social media and stuff like that. So it goes on and on and on, but it's really difficult, the shame and the silence around it. And that's even in the broader family. So you may have siblings that don't have this, and grandparents who don't understand, or potential grandparents, or people who want to be grandparents are pressuring you for this. So there's despair, but there's hope as well. So there's all of the, you know, so you're up and down, despair and hope, but lots of uncertainty and a lack of control. And these very stressful situations that you can't control, that influence the rest of your life, that is just a recipe for poor mental health and trauma. And there's so much grief and loss. Regardless of the outcome, there's often many losses along the way, depending on how you conceptualize it. And you need to have those grief processes in the middle of it as well. So massive stuff there that means that this really is a trauma, right? So my last couple of slides, this is post-traumatic stress disorder, and these are the symptoms that people will have as a result of all this biological dysregulation that's happening in their bodies and brains because of this experience of infertility. So there's flashbacks and nightmares. Flashbacks, and I will never forget those negative results, never ever, as long as I live. You know, I'm not having flashbacks and nightmares, but often people do, and the flashbacks and nightmares about those losses, and that's a characteristic of post-traumatic stress disorder. It's obtrusive. It comes at a time when you're least expecting it, and that's a problematic symptom. It often leads people into avoidance and numbing of emotional effect, and avoidance of anything that could possibly remind the person of what has happened. And of course, for infertility, that can mean avoiding a whole lot of stuff that's part of sort of normal everyday life. So that's really difficult. So people really change and rearrange their lives as a result of that. And then the hypervigilance, being on high alert all the time, waiting for the comment, waiting for something happening, waiting for the pregnancy announcements was something, I just hated that. Christmas is awful because of the emphasis on children. So there's hypervigilance all the time. And the 3 of those together are PTSD. And the good thing is that PTSD is a treatable condition, but the idea of providing PTSD treatments for this group, I don't think we're there yet. Our regional trauma network are seeing people who've been affected by the troubles, but we need proper PTSD treatments for people who have infertility as well, or who've gone through that. So I'm at the end now, and this was a really interesting study of PTSD and infertility, and I thought that the conclusion of this was that 41.3% of the women had symptoms of post-traumatic stress disorder, and the ripples of that then across families and communities, relationships, it's absolutely huge. So yes, this is a trauma, and we need to recognize it as such, and we need to provide the correct treatments. And as mental health champion, I'm going to work to try and make sure that that happens. So I'm excited to hear what your suggestions are today as well of how we can do better here. Thank you.
Siobhan, thank you very much. Really appreciate your time. I know how incredibly busy you are, so I think folks will have to wrap that up there. But again, Siobhan, thank you very much. Really enjoyed your presentation. So, folks, our next presenter is part of the organising committee, Gerry McCluskey, and I'll let Gerry introduce herself. She's a fertility counsellor. Over to you, Gerry.
Lovely, Derek. Thank you so much.
You're welcome.
Hi, everybody. I'm just fiddling around with a few buttons here. It is just lovely to be here. As Derek said, I am Gerry McCluskey. I'm a fertility counsellor. I've been a fertility counsellor for around about 20 years. And I worked at Family Roots for several years, right up to January. And I see some of my colleagues here. Lovely to see you. And I'm now working as a private practitioner in fertility counselling. My original training would have been in social work, and I would have continued in my social work role over many years. So if I can just find my talk. Today, as has already been mentioned, is about initiating and developing a dialogue about the trauma within infertility. I suppose my talk is not an academic one, nor indeed is it one with slides. It's just a series of reflections from an almost 20-year period of being a fertility counsellor. The dominant narrative within the research, within the literature, and within our experience in working with those who have significant difficulty in conceiving is undoubtedly one of loss and one of grief and grieving. Most patients tend to acknowledge the idea of loss and grieving as applying to themselves. So those who come to counselling can relate to that concept, and those who actually only come to counselling because they're required to do so, because maybe they're thinking about treatment with donation or with surrogacy. So they haven't sought out help or support or therapeutic work, but they also would agree that loss is a part of their journey, particularly as they move towards treatment with donation or treatment through surrogacy. There are so many additional levels of loss in that situation with regard to the genetic and the biological link with the child, to name just a few. The loss will be unique to each person, as will be their reaction. But a general story develops, a protracted and enduring emotional roller coaster, people oscillating between loss and hope, characterized by putting a brave face on in order to manage work and to manage just the daily tasks of living. And that separating your inside self from your outside self is something we all do from time to time. But doing so for a protracted period of time takes a lot of your resources which are then reduced for other things. Thinking about treatment, planning treatment, managing work and treatment, finding the money, counselling, career development opportunities, not going for job interviews, not planning holidays, not actually doing that house move that you'd hoped for, just in case you might be having treatment, or indeed because you might be pregnant, is all consuming. No wonder then that people describe themselves as having effectively change their personality. They see significant changes in their personality and worry about those, worry that that's going to be a fixed state. They don't recognize themselves. They've never been that envious, jealous person who can't face their lifelong friend who is now pregnant for the second time, or the one who doesn't enjoy socializing anyone anymore because they haven't the energy. They can't experience fun and joy as they once did. They need to avoid the baby pregnancy questions and announcements. Descriptions of sitting outside in the dark and cold, watching a family party going on in a warm, well-lit, joyful looking house, a party that you can never join. Or being lost at sea, helpless, alone and without any land in sight. Or struggling along a road strewn with barbed wire and landmines are not unusual metaphors in the counselling room. The loss of an imagined child, an envisaged future, loss of identity, confidence and self-esteem, loss of control and choice, inability to negotiate a natural life stage to achieve a normal, recognised role in society, is essentially a loss of a sense of self. Jorgensen, way back in 1981, described infertility as, in a physical sense, an assault, a wound to my body, to my psyche and to my soul. These are high-order threats or losses which surely qualify as emotional and psychological trauma, dependent on the perception of the individual. Added to this, we have the more tangible losses experienced within a fertility journey: embryos failing to thaw, treatment not working, missed miscarriages, chemical pregnancies, early pregnancy loss, ectopic pregnancies. All have their own potentially traumatic impact, which we'll hear more about from Professor Bourne. And to say that I suppose the individual perspective is so important, because some people will see their embryos as their babies. Some people will name the embryos that are frozen. So when they fail to thaw, it is certainly a major loss for those people who view that in their way. Taken together, the emotional burden of a fertility journey is heavy. Having to learn each month, each treatment that you have not conceived, knowing that you have a limited time span in which to attempt treatment, adds significant pressure. There's little doubt in my mind that, dependent on the perception of the individual's infertility, fertility journeys satisfy the NHS's definition of trauma. And I quote, "Trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as harmful or life-threatening. While unique to the individual, generally the experience of trauma can cause lasting adverse effects, limiting the ability to function and achieve mental, physical, social and emotional or spiritual well-being." And I think anybody in the room, and certainly any counsellor in the room who has talked to people, will recognise that completely, as many of their patients who come through the door for support and intervention. So when are we actually dealing with loss, and when is it actually trauma? And when is it a variant of trauma, such as post-traumatic stress or post-traumatic stress disorder? Are we in the fertility field trauma-informed enough to be able to identify the difference? And are we suitably trained to respond appropriately? While completing a year-long trauma course some time ago, I did what we probably all do, remembered people with whom I'd worked and wondered if I had missed signs of, in this case, trauma and specifically PTSD. I had the opportunity to see some of the people again, and I deliberated over whether to use a PTSD symptom checker. I didn't want people to feel labelled, didn't want them to consider that they had significant problems. I didn't want to pathologize people. And I felt a wee bit of responsibility for being perceived as diagnosing, which of course I can't do and I wasn't doing. Haven't got over those hurdles. I learned a couple of things. One of them was that the amount of significant information about the people that we work with that we don't know is in itself very significant. Counselling is generally client-led and the focus is on what the person brings to the session, which appears sufficient for grief and loss. But trauma work requires a different approach. It made me wonder about screening and assessment in the fertility field. On the one hand, such assessment, certainly for counselling, can seem a bit heavy for routine counselling. Probably impossible to do in the limited number of sessions that some clinics allow. Not here, I hasten to add. Our clinics have very generous levels of counselling, but some clinics only permit one session. The rest must be paid for. And Hilary mentioned about the rates of people who would prefer to come to counselling if it wasn't paid. How can you understand and work with the trauma you are seeing symptoms of in the room if you have no idea about whether it is a current trauma triggered by the fertility experience and fertility treatment, or it's actually a prior trauma that is being re-triggered by the current treatment? The other thing I learned was that people actually welcomed the idea of trauma. Instead of it being a threat or a stigma label, the people actually welcomed the idea. They felt it actually matched what they were feeling and how they were behaving. They felt it explained it. And therefore there was a process of beginning to feel less self-blame. There was a process of validation went on. And that whole issue of beginning to externalize the problem could begin. And I suppose those of us who work in counselling are so much aware of how important it is to validate the experience of the people that we are actually working with. Calling the person's experience by the right name is an important first step in helping a person to process psychological harm. The three classic symptoms which might distinguish loss from high-level trauma are, as Siobhan mentioned, persistent re-experiencing, avoidance and hyperarousal. Avoidance is actually, in the fertility experience, a self-protective behaviour for many people. We often hear stories about not attending christenings, baby showers, visiting friends who have just had babies in hospital. These are big talking points in counselling rooms. Sessions can be devoted to managing the disappointment of somebody because a friend or how to manage a family event by not attending and not offending those people. It's also a big discussion in support groups. So when does avoidance stop being protective and actually become a trauma response? How would we pick that up in any of the services within the fertility sector? Reports of distressing dreams following failed treatment, persisting for several months, triggered at a later date by another loss, or on hearing of a stepdaughter's pregnancy when you have never been able to conceive. Is that loss, or is it unresolved trauma symptom? Fertility patients are very, very tuned in to knowing when somebody is about to tell them about their own pregnancy. It's almost like a sixth sense. Is that hypervigilance? Anxiety, depression are part of a fertility experience. When are they indicative of trauma? Is the person who avoided exploration of egg donation until after the birth of her child experiencing postnatal depression or a trauma response? And what about the people who resist attaching to their baby well into their pregnancy? An understandable protective reaction. Fear, avoidance. Or the highly anxious pregnant person who needs weekly scans and isn't sleeping, or the hypervigilant first-time parent who fails to live up to her own standards of parenting, confirming her negative cognition, her core belief that she was never meant to be a parent. Understandable after a fertility journey? Absolutely yes. A loss experience or a trauma symptom? Undoubtedly the answer lies in the nature, degree, extent and range of symptoms and behaviours embodied in the one person. But how do any of us involved in the person's treatment and care know when to refer somebody for specialist intervention? Who and what services within the fertility field need to be at least trauma informed in order to identify trauma? And if we do think specialist intervention is desirable, to whom do we refer? What's the pathway? And how responsive can those services be? I know that I've raised more questions than given answers, but it matters. It matters whether the person before us is experiencing loss or trauma. It matters that we call the experience by its proper name. The interventions are different. The creation of safety and avoidance of re-traumatizing are important. Identifying trauma earlier and intervening appropriately may prevent or reduce the impact during pregnancy or in early parenting, or as people negotiate their life without children. Thank you for listening, everybody, and I look forward to hearing the rest of the talks today, reflecting more on trauma within infertility and considering where we go to next. Thank you.
Hi, I'm Rosa Glover, and I have just recorded my visit video to you, which is why I look like I've been crying, because I have been crying. So that's why I wanted to come and do this introduction without changing anything or masking anything. I was asked to share my story, and I thought I wouldn't be able to fill 10 minutes, but it turns out I could fill 25 minutes, so I've had to cut it right back, and this is my new introduction to my story. I'm 40 years old. Had a 6-year infertility journey, which included lots of investigations, operations, IUIs, and finally an IVF that was successful. But it was a long way of getting to my IVF, and I was extremely lucky for it to work first time. Unfortunately, my little boy was born at 24 weeks, so I experienced a second trauma of premature baby, and we lived in the neonatal intensive care unit for 3.5 months. But I just wanted to quickly introduce myself, and I've submitted the list of traumas that I went through, which I hope doesn't come across as a list because it's not meant to, but it was just the easiest way for me to organise my thoughts around what we were talking about today. So yeah, please enjoy. Thank you. Start with the trauma right at the beginning of no pregnancy every month. It's so much more severe than anyone can explain. It's bad enough getting your period. It's bad enough bleeding every month. It's bad enough having to factor that into your everyday life, into your social activities, into your sex life, into your going out swimming, whatever. But then knowing that that is a signal of yet another month that's passed by, another turn that wasn't yours, another chance gone. And I thought that's where it starts, you know, like, and people don't get it. Oh, I've got my period means nothing to somebody who isn't trying to conceive, or who isn't going through infertility. But every month seeing that bleed and knowing that you're about to not be pregnant again for another 30 days is heart-wrenching. And that's just the beginning. That's before you even start factoring anything else in. So then what's next? The trauma of friends' pregnancies. Every month that you go by every 12 months turn into a year. so, you know, 4 years down the line, and I'm still trying, and my friends are on baby number 2, and I was thinking we were going to have kids at the same time. So that's immense. It puts a wedge in between you and your best friends. You feel like you can't talk to them. Suddenly your social network changes. Suddenly you're the odd one out. You're not invited to your friends' children's parties because you don't have a child to bring along with you. And so it's like a double whammy. Not only are you feeling really crappy about not being pregnant, but suddenly you're not in the same social circles as people, your friends, anymore. Then there's the trauma of the testing and the scans and the waiting that hits you when you finally do get to go through and accepted. Yes, you've been trying 2 years. Yes, you've had X amount of miscarriages. Now we'll accept you. Now we'll help you. Yes, we feel like you have suffered enough. We will help you. But first of all, you have to wait till this day of your period to have this blood test, and then 30 days for the results. And then we need to scan you, but there's a waiting list and it just goes on and on and on. And you just constantly feel like the time is ticking by. Every month, every week that passes, you're less likely to be that thing that you're put on the earth to be. And yeah, that's painful. I was lucky. The team that I went to at Nottingham were amazing. I had so much support. I felt like I was a real person, felt like I had friends around me, and the nurses that really cared about my results. I had a very positive experience, but I know that a lot of people don't. So when I went through and had my first IUI, my second IUI, and me and my partner saw the faintest positive line on the pregnancy test, we were beside ourselves. And I'm talking the faintest line you've ever seen. We pulled the test apart, we took pictures of it, we enhanced the pictures to see if it was really there, and we really believed it was there. And then to be told, no, chemical pregnancy, move on, in little more than those kind of words, is crushing, because you've waited 6 years for this, and you've gone through this tests and the blood tests and the IUI, and you really feel like finally you've made it, and you haven't. And it's breaks you, absolutely breaks you. I still remember the pain of it now, the pain of my mum driving me to the hospital, having to sit for the blood tests on my, you know, and then just the nothingness of it. Then there's the silly little things, you know, like the IVF videos that you have to watch and sign off to say, yes, you're aware of multiples. Yes, you're aware of the chance of premature. I don't care. I didn't care at that point. You could have told me the chances of my child having 2 heads are 90%, and I would have done it. I still would have gone ahead and said, I want this. This is what I want, because I was so desperate at that point that was the only way I could seem to move forward. And they make you feel like you're on some kind of journey that no one else is on, and you're having this kind of special treatment that you really don't want. In fact, it's a well-known saying in the fertility clubs, you know, infertility, it's a club that you never want to be part of, but you never dreamed you'd be part of, you never want to be part of, but you're kind of glad that everyone else is there because they're the only people in the world that understand what you're going through. Then there's the trauma of the cost of the failure, and I don't just mean cost, I mean like financial cost, yes, but the cost of everything you've given to that point, the energy, the getting up at 6 o'clock in the morning to drive to the clinic every day, to have your scans, and I'm talking an hour and a half each way, you know, it's not small. If you don't have an employer that knows what's going on, that's a whole other world of stress behind that. The financial cost then comes into it, you know, what do we do if this doesn't work? Who do we borrow from? Where do we get from? What can we sell? Because they're real. Those things are real. You don't care at that point. You will find that 5, 6, 7, 8, 9 grand to go through this, and you don't care what debt you're in to get to the end, because all you think about is the end result and being a mum. Then obviously there's the constant waiting of the IVF treatment. Sorry, that's my partner turning my stage lights off up there. Can you turn it back on? That's all right. The 5-day wait after the treatment's gone, when there's nothing you can do apart from wait for that call every morning to be told how many embryos, how many eggs you've got. There's nothing. You feel so out of control. You are out of control of something that you feel like you're meant to be completely in control of. That's meant to be natural. Then we sadly and luckily, I don't know, had 12 eggs, 8 embryos, but then on day 5 we had 1 embryo. So we had to, and because we were in the middle of the very beginning of COVID, before the treatments were paused, we had to make a very quick, immediate decision as to whether or not we wanted to go ahead, knowing that freezing and thawing might be a potential, you know, we might possibly lose the 1 embryo that we had. So we went ahead and we decided we would go straight away. And that in itself was a trauma, you know, that decision being put onto our shoulders. Do you freeze your 1 chance after 6 years because you're being told that the NHS might not be able to cope in 9 months' time because you don't know what COVID's going to do to the NHS, and there might not be beds in the NHS for you to give birth, and everything you've worked for the last 6 years has been for this 1 chance, this 1 embryo, this 1 time that you might be able to become a mum, and you're being asked to put your everything against the, you know, safety of other people, safety of the elderly. It's awful. And I was selfish, and if you want to look at it that way, and I said, look, this is my 1 chance, I'm sorry, but I want to go ahead. And luckily, I believe, you know, I know how lucky I was that we were, that our little embryo worked and we got pregnant first time. And I know that is a very unusual story for IVF. And there are not many people that get to say that their IVF worked the first time. And we are beyond lucky and grateful for that. I mean, obviously, from my point of view, 24 weeks in, I ended up getting contractions and my little boy Kit was born. And well, the world turned upside down for us. We lived in NICU for 3.5 months. And that was massive, that trauma. I still haven't even began to unpick that as an experience. But we came home. We came home with our little boy. He's fit, he's well, he sleeps sometimes, but he's here and he's healthy. But I do have to be honest when I'm saying that now I'm thinking about baby number 2 and what that means and the pain that will cause me and the pain it will cause me if we don't go ahead. So we were extremely lucky, and on day 6 we were told that actually that one of our embryos, day 5 embryos, had actually turned out and made it to a day 6 embryo. So we were told we do have an embryo. So now it's, to not want to sound ungrateful, the trauma of knowing what to do with that embryo. We can't keep paying every year to store it. I'm 40 years old. We've got, 8 years left that we'll be allowed to store it. I think, is it 8 years? But if I can't go through that trauma again of the IVF and the uncertainty and the cost of it, will I ever be able to forgive myself that I've got a potential human being waiting for me to make that decision, waiting for me to I do have tissues. I was ready. I feel like I'm a strong person who
is comfortable talking about my feelings and my experiences. And for that reason, I got through this experience because I went out and I found people who were going through the same thing as me, and people I could talk to and share this stuff with. And I went out and asked for help. I got, went to my doctor and got medication and got therapy, and found groups, Fertility Network groups, where I could find other people that were going through the same thing as me. But I feel like if I wasn't the person I am and couldn't talk about these things and didn't know how to find support, then I don't know if I'd be here today to tell this story, because the pain involved in the journey is not comparable to anything else I've ever really experienced. So, not wanting to really end on such a somber note, my IVF clinic were amazing, supportive, but is that because I was successful? Would I have felt like that? Would I have felt so positive about the experience if I hadn't have had a little boy at the end? I don't know. Yeah, I don't know. But I just want to say thank you to everyone who's trying to do something about it, trying to raise awareness of what it's really like for people who are going through infertility, for people who may not ever be able to realize the dream of being a mum or a dad, people who are making it less of a taboo and making it more of a everyday conversation, and championing support for people going through such horrible, awful situations. So yeah, thank you all for listening today, and yeah, thank you for the continued support for people who are going through this journey. All right, I'm going now. Bye.
Moving on to Professor Tom Bourne, and as you'll have seen his bio, it's very impressive. So I'm really looking forward to hearing this presentation. So if you're happy to take over the screen, Professor Bourne.
Well, I guess you go to me.
Yeah,
okay, hi. Well, good morning. Thanks very much for inviting me. I am an obstetrician gynaecologist, so I'm an amateur in your presence, basically. So do feel free to throw things at me and give me lots of abuse anytime you like. But I do have an interest in this area because clearly the psychological impact of events in pregnancy should at least be highly relevant to obstetricians and gynecologists, although I'm not sure it's always been taken as seriously as perhaps it should have done. But anyway, bear with me, and I'll just share my screen. And what I'm going to talk about really is early pregnancy, which is often the Cinderella when it comes to pregnancy. It's a massive issue. The number of miscarriages worldwide are something of the order of about 22 to 23 million. So when you start looking at it in that context, if there are significant psychological sequelae, the potential for both personal and societal harm are enormous. So I'm just going to present a little bit of work we've done and talking about how common issues are maybe in relation to miscarriage and ectopic pregnancy, just to try and illustrate that point today, if that's okay. So where is my screen? That's that. Always good to have the slides on the right place. Okay, so I hope that's all there for you. Well, you know who I am, we've done that. And once again, thanks for having me. Just say I work at Imperial College. There's an idea of numbers. We have about 9,000 to 10,000 deliveries each year at our institution. And we see about 18,000 early pregnancy patients as well. So we have quite a lot of throughput. I always think, if you want to kind of really get an idea of the feeling or how people are following in relation to anything, go to art. And this is a painting by Frida Kahlo, who I think is a wonderful painter. But this is a picture which she painted of her in the Henry Ford Hospital in Detroit after she had a pregnancy loss. Now, Frida Kahlo is an interesting lady who went through a lot of pain in her life. She had a major bus crash when she was very young. She had various rods and pins in her body. She was a pretty resilient person, but you can see just looking at this how devastated she was. And you know, the symbolism here of the baby she never had, her pelvis that in her view let it down, the flowers from her husband when he came to visit, and all these things kind of give you a little bit of insight into the impact of loss. And Frida Kahlo sadly never did have a successful pregnancy, and it's one of the great regrets of her life. But in a way, you could leave this talk here, really, because, as I said, it kind of tells you all you need to know. Now, I mean, if you want to find out about stuff these days, you tend to do systematic reviews. We can talk about the relevance of those and the quality of some of them. But if you want to look at the psychological impact of early pregnancy, not looking at the literature, this is one of our PhD fellows, Jessica Barron, carried out this review a while ago now, and actually found, perhaps not surprisingly, there wasn't as much work in that area as you might expect. There's not that many studies, 27 studies, 2,500 women. And in fact, looking at 1 month after the event, high levels of what you might call psychopathology, particularly anxiety, moderate to severe anxiety, depression, not to the same extent, but really very significant levels of post-traumatic stress disorder, and which, you know, from what I gather, is one of the main discussions of the meeting you're having today. Partners also have a problem, but it is lower, but it's not negligible. And so the conclusion of this systematic review is there's significant risk of psychological morbidity. There's large variations. We don't know very much about post-traumatic stress because it's actually only 3 small studies. And none of those studies control for having future losses or successful pregnancies during the follow-up period. And there's no data on ectopics, and most of the data is 10 years old. So there's an issue, but we're not really sure how big that issue is, and the data is fairly scarce. Based on this, we went and did a pilot study. 175 women, 95 miscarriages, and 24 ectopics compared to 56 viable pregnancies. Okay, we used fairly basic stuff. The HADS and the PDS at that time was suitable, but obviously the DSM criteria have changed between when this study started and, as you saw from the previous speaker, the DSM-5 now, but we could use the PDS at that stage. And when we present any data in this talk, it will only relate to moderate to severe pathology. There's a lot of people with, so mild, but certainly significant symptoms below the threshold who are very much troubled by, you know, the events, but we're not counting for the purposes of the data I'm presenting. And you can see there is, not surprisingly, a certain amount of anxiety and depression in the control group, if you like. But if you look at anxiety, you know, there's a significant amount of anxiety, as you might expect, 1 month and lasting up to 3 months. Not so much depression, but the big issue is post-traumatic stress, where, interestingly, 3 months after the event in the miscarriage group, 45% of the women in this cohort were suffering from significant levels of, or significant post-traumatic stress symptoms. I say that because obviously we're using a validated tool, but not sort of face-to-face diagnosis. We did actually subsequently do skid interviews to validate what we were using, and it did show very good sort of correlation. But in any event, this was rather, well, certainly surprised us how high this was, and in fact it was so high we didn't really believe it. But in any event, it caused quite a lot of publicity, not generated by ourselves. And I say that all over the world, people reported this study, which is kind of ridiculous based when you consider the relatively small numbers. But I'm putting this up here because I think it just struck a chord with so many women, not necessarily because of the quality of the paper, but because it was being talked about, and there was so much discussion about it, as if people for the first time had suddenly said, actually, you know, I have suffered for years following my miscarriage and I've never felt able to discuss it. Okay, following the pilot study, we went on and did a somewhat larger study, which was appropriately powered up, which was published in AJOG in 2020, which is available if you want to just download it. And this was, we approached over 1,000 women, 730 odd agreed to take part. And we also had a control group of healthy pregnancies. And we also had 192 partners in this study using the same tools. There was significant dropout, which is always the case, as you can see from the completion rates down here. So you need to take that into account when you interpret the data, and people drop out because they're too traumatized to take part, or they're so unbothered that, you know, thankfully they've moved on, they don't want to take part either. And there's, you know, there's a variety of reasons why people drop out, but we do need to be aware of that. So if we look at the data, the control group, you know, as you would expect, there's anxiety and depression in the control group, but no post-traumatic stress, and we did screen for traumatic events in the recent past in the cohort. And you can see that there's quite a lot of moderate to severe anxiety, and it persists. You know, quite high at 1 month, 3 months is 23% of women. It does drop down, but there's still an increase compared to, if you like, the control group of normal pregnancies. So there is an impact, and it's still there 9 months after the event. Depression is at relatively low levels. Moderate to severe depression is 3 times higher 9 months after the event. But when you say 3 times, it's going from 2% to 6%. So the overall burden is not high, but there is a significant increase. And yet again, you know, I won't go into the scoring. I mean, we tried really, really hard not to score these people high for post-traumatic stress with PDS. But even so, 29% 1 month after the event had very significant post-traumatic stress symptoms, tailing off, but still, I think I can't see because the box is there, it's about 18% overall 9 months after the event, 21% for ectopic, 16% for miscarriages. So this is a very, very significant burden when you think about it. 9 months after the event, when you consider there's 23 million women worldwide who are suffering from this condition. By that I mean miscarriage and a significant number of ectopic pregnancies. For some reason, oh, there we go, hang on. Yeah, and I think what's going on, I mean, you can see there's a sort of, if you look throughout here, we have this sort of cohort of women who simply are not resolving their symptoms. And I think if you look at post-traumatic stress symptoms, as all of you well know, they will carry on troubling people for a long time. And I think we didn't follow up beyond 9 months, but I'm absolutely sure that these patients will still have significant symptoms, possibly for years, untreated. We tried to look at risk factors for significant morbidity, and none of them were particularly significant. This is at the AUC, so it's 0.66 is not particularly predictive, but their own feelings of responsibility and concerns about their own well-being were relatively high up. A previous psychiatric disorder, perhaps not surprisingly, any previous losses, and length of time taken to conceive. So these are perhaps, slides are perhaps the things you would have thought so beforehand, but when you're talking about fertility, people who've had fertility treatment or taken time to conceive, had previous losses and have underlying issues, are all people you want to flag up as being highly likely or at risk of developing psychological morbidity following a pregnancy loss, and perhaps should be brought back for review. Now, I mean, I said that I think these symptoms will continue to last. We haven't, unfortunately, just did not have the capacity to follow these women up for longer. But there are some hints as to what might be going on. This is a paper from a while ago now, 2009, from Gerry Biss's group in Holland. And he was looking at people with termination of pregnancy for fetal anomaly. A very different situation, but in the end, the loss of a baby. And they were followed up to 16 months. And again, using a different scale, they were finding that approximately, you know, very high levels, 20% or so of women had significant post-traumatic stress symptoms at 16 months. So in other words, it's quite, you know, as usual, this number of 20%, around about 20% following a traumatic event, seems to be the case in early pregnancy loss, and it seems to persist. Interestingly, they did a retrospective study. They went back and looked at these women some years later, and looking at data, and they found that, in fact, these symptoms, you can see there's a drop-off over time in these women in terms of post-traumatic stress symptoms, but many of them were still troubled quite significantly 2 to 7 years later you know, one presumes, I suspect, that there'd been little or no intervention offered for these people, because generally, certainly up to now at least, most people with early pregnancy loss to some extent either accessed self-help groups, online, miscarriage association or whatever, but certainly were not offered much in the way of intervention. So the potential here is really huge. If you think about the proportion of women having a miscarriage in the UK each year, some might estimate about 500,000. So 20% of those are developing significant psychological symptoms which persist, and therefore you're accumulating that number of women each year in the population. It's an enormous burden. And you will all know, because you're all in this topic, that remission from post-traumatic stress disorder in the general population, in other words, the non-pregnant scenario, you know, you do get better, but these symptoms will last and trouble you for years. Certainly my father, who's in the Second World War, hence my poppy today, had post-traumatic stress all his life. And certainly some of his friends who went through the war with, for example, committed suicide in their 60s, which of course was devastating for my father. So these things do not resolve. Size of the problem, well, if you look at it in the States, for example, there's 4.5 million pregnancies each year and about 900,000 end in a loss. If you have 20% of women have moderate to severe post-traumatic stress symptoms, just do the mathematics. The numbers are actually mind-boggling irrespective of how, you know, these women have you know, significant problems. What about partners? Well, we looked at the partners in this study, and this paper, again, it's open access. And of course, there is a difference. You can see here in green, meeting the criteria, month 1, 2, and 3. Green are the women, and blue are the partners. And you can see that about 4% of the partners had moderate to severe post-traumatic stress 9 months after the event. Now, yes, of course, it's a lower level than all the patients. Sorry, this was all women by chance. When I'm just talking about who was coming in here, so all of their partners happened to be men as well. That was just the way it came about in terms of our consecutive recruitment. And 4 to 5% had post-traumatic stress, but that's still quite high. It's about 1 in 20, so it's not insignificant. A reasonable amount of anxiety and some depression, but certainly men are impacted. And of course, if you look below the threshold, there's going to be a lot of people who are troubled with quite significant symptoms, even if they don't meet this threshold, which is to some extent somewhat arbitrary in any event. And if you look at the clusters that have been endorsed, for example, in men at 9 months, and you talk about, you know, helpless, terrified, helpless and terrified, you know, the percentage-wise, individually, these people are endorsing, you know, arousal, interruption of activities. Quite a lot of them are finding it's impacting on several of their activities and still having quite significant symptoms, even if they don't end up, you know, if you like, being classified with having post-traumatic stress. And obviously in the women, in this case, these are significantly more. But just because they don't cross that threshold doesn't mean that they don't have problems or are significantly troubled. And perhaps this is one of the reasons we see this sort of data, these data, where because there is a difference, you can see this is marriage and cohabitation outcomes after pregnancy loss, and there's a difference, you know, between live births and miscarriages and stillbirth. And you know, when you have two people, I guess, who have, you know, somewhat different psychological responses to an event, it's perhaps not surprising that you do end up in relationship breakdown. And one does wonder whether a proportion of this is to do to unmanaged post-traumatic stress in one or other of the partners, because we do know, of course, that does lead to relationship breakdown as well. So, you know, there is costs for the individual, costs in terms of relationships, and there's also costs in the workplace, because obviously a number of people with these sorts of problems will be struggling in the workplace as well. So, you know, from a government point of view and a policy point of view, dealing with this, and this is just, this is in pregnancy loss, should be, in my view, a huge priority. But without data, of course, governments tend to do very little. So you have to have data to drive policy. And I think we heard this from our previous speaker. And it's the sort of thing that you hear people saying, kind of qualitative quotes. We have lots of this, but we haven't done a proper qualitative analysis. If any of you are great at qualitative data analysis and writing about, you're very welcome to our data on this to do that with. So why is it important? Well, it's massively important. I mean, and this is a particular cohort of people, I think, who are uniquely positioned to have problems because of the problems in early pregnancy that people don't tell people they're pregnant for a start. There's this so-called 12-week rule where people think, well, I mustn't tell anybody. But of course, when things go wrong, there's nobody to talk to because nobody knows they're pregnant in the first place. And I know Katie Lindsay wrote an article where she talks about Schrodinger's pregnancy. You're pregnant, but you're not. So there's a real issue around support, the sort of self-blame and guilt around the cultural taboos in many cultures that exist around miscarriage are hugely impactful. And the fact that people are supposedly being told it's kind of routine, and that's reflected in the workplace where women up to very recently were not given time off or had following an early pregnancy loss. You see it in mid-trimester miscarriage, where if someone has a terrible event to have a stillbirth, quite absolutely rightly they have a huge amount of support. But if you're miscarrying at 16 weeks, you're often put in a side room on a gynae ward with very little support at all. And the problem with miscarriage, which is unique, is you then have to re-expose yourself to the trauma to have a successful pregnancy. You go back to the same place. You often go back to the same place for a scan, and it's a really, really tough thing to do. And it has this wider impact as well. So, we could talk about that, but, when women have had a loss, or if they have recurrent pregnancy loss, they're incredibly brave to keep putting themselves in that position. In terms of what you do, the evidence to follow up is not fantastic. And what about treatment? Sadly, the Cochrane review, which to some extent a lot of people still go on, because the number of studies is relatively small, basically concluded that there was really insufficient evidence that psychological support is beneficial after miscarriage, which is interesting. But of course, the problem also is they're looking at the wrong people anyway, and they're not in any event targeting support to certainly towards the 20% of women who have real issues. I mean, I'm not saying the others don't, but many of the women who have not had post-traumatic stress or whatever will perhaps get better by peer support and supporting pregnancy support groups and so on. But there's a substantial proportion who simply will not get better, and I'm sure that makes a big difference to the studies that have been carried out, or some of the studies that have been carried out. But anyway, that's Cochrane at the moment, and that evidence base needs to be moved. Targeting psychological impact, well, I think, we have to understand the impact, and we don't understand at the moment what impacts are that cause the problem, whether it's the type of treatment, how we are as doctors, the trauma of the loss, because you have two issues here. You've got grieving for the loss, but you've also got the physical issue surrounding the actual loss. And I can show you pictures of people miscarrying if you want, but I'll spare you that because I'm sure some of you have miscarried yourselves, so I'm just going to be more traumatic. But anyone who says that miscarrying, is not traumatic, clearly do not know what they're talking about. And there's a few things we need to think about doing. We need to think about reducing the trauma. We need to, if we can, or what aspects are traumatic. We also perhaps can try and prevent the post-traumatic stress happening in the first place. And there's some interesting work done at the moment. This is Imperial, which some of you will know about Emily Holmes's work, where carrying out a brief cognitive task almost immediately following the event can reduce intrusive memories and flashbacks. And the cognitive task, bizarrely, that she has used is playing Tetris. Those of you who are old enough to remember Tetris, of which I am one, unfortunately, it's a very simple computer game where you rotate blocks so that they kind of fill the space. And so there's a sort of exercise you go through with the patient where you sort of ask them to mentally, I don't know why my slides are going automatically, sorry, to mentally rotate these blocks to actually sort of fix their minds on this mental rotation. And it appears, at least in some data at the moment, this can reduce some of the post-traumatic stress symptoms and indeed prevent it. And this is now being trialled in ITU workers following COVID and quite a number of other situations. So, for example, this is a paper from Emily's group, Karolinska in Oxford, in an emergency department, and there's some evidence, and you can see down here that the number of intrusive memories in these patients is being significantly reduced following this type of intervention. So, yeah, you'll all know more about some of this stuff than I do, but we're currently in our unit doing a randomized trial of a brief cognitive task. So obviously it's randomized, so I don't know the outcome yet, but we'll have that data in January and know whether this makes any difference to stopping people getting some at least of the symptoms of post-traumatic stress. So maybe prevention in this way may be helpful. But also, this is the actual study. This is the PICO for the study, and they get this intervention within 72 hours of the event, actually, when they're diagnosed or have the miscarriage. In terms of trauma-focused CBT, again, this is, I'm telling you stuff you know. I was just listening to what you were all talking about before, so obviously you know all about this, so I won't bore you to tears, but obviously there is evidence of trauma-focused CBT and also EMDR, which is obviously something which a lot of you know an awful lot more about than I do. And clearly, we do know these things have an evidence base in adults, but interestingly, the evidence base in the miscarriage population is really not there, and so it's rather annoying when you go and talk to NICE and people like that, and they say, "Well, yeah, that's great, but you know, there's no data on women following pregnancy loss," and it seems a bit, you know, ridiculous to me because you know, it seems unreasonable not to offer it. So these are other papers relating to, this is a paper relating to CBT, trauma-focused CBT in this population. But as I said, this is not actually mostly miscarriage, this is just loss of a child. So I don't see why you can't, I mean, you can tell me if you can't extrapolate at the moment, but at the moment there are a lot of people trying to get funding for a sort of large trial funded by NIHR in this direction, and there are, I think, mainly based around Ari Kumarasamy and the Birmingham people trying to get money to do a trial. Having heard you today, then obviously they perhaps ought to put an EMDR arm in, but maybe that's a conversation that you could be having, or we could be having, or Ari could be having with you. So, you know, this trial would involve screening people for symptoms and then an intervention, probably at 3 months. But again, we can talk about whether that's the right thing to do. I'll just say something about prevention. I mean, one of the things we just don't know what it is that makes the trauma worse. I mean, I'm sure there's a baseline level of trauma associated with a pregnancy loss you're never going to prevent. I guess one thing might be that we might just not call, you know, get what we call things right. You know, Katie Lindemann I like very much. I know her quite well, but she wrote this in The Guardian, and how right she is. You know, we call babies, you know, if they've unfortunately died, products of conception. You know, when someone's baby's died at 7 weeks, it's a baby. It's not, you know, it's incredibly insensitive. The dementia we use around pregnancy loss, and the loss is made worse by the language. You know, if we look at everything that we talk about in obstetrics and gynecology, from you know, blighted ovum to incompetent cervixes, I really think people need to think very hard. And just simple things like, you know, spontaneous abortion is still used. And that upsets people a lot, and you read in the literature. I mean, simply call it a miscarriage. Surgical management of miscarriage should be the standard, not evacuation of retained products. So there's some very simple things. All these tiny things add up. Everything you do when you see a woman with a pregnancy loss, they remember probably for the rest of their lives. You know, and you know, it may be 15 minutes of our day. In my particular position as a consultant, I see but it's the rest of that person's life. So you have to be extremely careful with everything you say, everything you do, even how you know, comport yourself, and even sit is something that people will pick up on. And of course, more widely, societally, I think we have to change the prevailing attitudes in the workplace, where, you know, women are treated appallingly in the workplace in relation to miscarriage, often even made to stay at work while it's happening. They're given no time to recover afterwards. some companies are enlightened, but it's a major issue, and everyone should be putting pressure on governments to change around that. Some people in New Zealand, for example, has changed things, but the UK government certainly has resisted change so far. I don't know about what's going on in Ireland, but there we are. One thing I will say is that one of the issues relates to the people who are actually seeing the women. This is a study we looked at burnout amongst obstetricians and gynecologists in the UK, just to highlight the point that 43% of trainees fulfilled the criteria for burnout and 31% of consultants. And as we all know, burnout is associated with lack of empathy, increased patient safety incidents, and reduced quality of care. So if you've got doctors or sonographers or midwives, and we know from other data that midwives are very burnt out, one of the things that's never really talked about in detail when you listen to yet another inquiry about maternity scandals is the health of the workforce. And, you know, some of the behavior you see described in maternity units is really slightly beyond comprehension, but it's entirely understandable if you look at the context of people who have been burnt out, whose empathy has simply disappeared, and where they've become quite cynical and quite callous in their attitude towards patients. So if you've got unwell professionals taking care of people, I think that's a major issue and will also compound the situation. So just to summarize, you know, probably quite a lot of women following miscarriage will feel better after non-specific counselling or peer support, and will in effect adjust over time. Not something, obviously they'll never, you know, you don't move on, as a horrible phrase, but they will to some extent, you know, get better. But a significant number will not improve quickly, if at all, and are currently offered minimal support in most settings. You know, if they have significant post-traumatic stress without intervention, they may well have that problem for an awful long time, which will impact both on their situation. We see lots of women who say, look, I'm sorry, I cannot face getting pregnant again. It was so traumatic last time. And we need to think about how we target people who are likely to have post-traumatic stress or screen for it. And we can discuss how that might be best done. And we need to decide also, there needs to be some coalescence around what the appropriate intervention is. And I think you are all better probably qualified to comment on that than I am, but whichever way we play it, we need to have data to persuade policymakers to fund appropriate care for these people. I won't show this because I haven't got time. So I'll leave you, I think, again with Frida Kahlo. Here we are, sitting there in painting. A doll is usually a representation of a baby. And when she painted this was her statement that some years after the event, she was still sitting there on her own, and that represented the baby that, in fact, she never had. She never ever really got over it. And I think that's the case for a number of women who have a pregnancy loss. So thank you for asking me to speak. I hope that was of interest.
Before Derek, we move to Sophia, I mean, again, can I just reiterate the thanks to Tom for that presentation, and also to Marlene, who I caught the end of. Certainly you made quite a mark, judging by the comments in the chat. If I can, Derek, can I ask a question?
You work away. Yeah,
just sort of based on the chat. Tom, maybe even you, Marlene, from a sort of research / clinical viewpoint, but do you have any evidence to suggest in terms of re-traumatization and people who are having, you know, maybe more than one miscarriage or maybe more than one cycle of infertility treatment or something like that? Is there a compound effect, I suppose, is what I'm asking?
Well, I don't know the answer to that, because on fertility we haven't got the data. In looking for this study, I mean, in particular, in fact, for our study, we controlled for people having further losses, basically, and also for having further pregnancies. So, in a sense, I can't comment because we deliberately took that out of the equation because we didn't want to look at that. But on the other hand, you turn it around the other way, and you know, re-traumatizing yourself seems to me very unlikely to be a helpful thing to be doing. That's all I can say.
Yeah.
And I think that is you know, one of the key issues. I mean, you know, I think I'm sorry I didn't hear all the speakers, but you know, clearly, you know, fertility treatment, the very fact of coming to terms with fertility itself and perhaps in itself is traumatic for many people. But then going back to have scans in an early pregnancy unit and losing and being given a loss. And I was talking to Tulip Mazumba. We did an interview with Tulip Mazumba on stage. I could actually put the link up, actually, if anyone's interested. And she spoke about the fact that, she knew the room, and she went back to the same room and the same sonographer for something like 3 or 4 consecutive miscarriages. And she could tell you, yes, it's room 9. And the very thought of going back there was traumatic for her. And of course, for most people, they've got one local hospital. They may well see this, it's amazing, actually, when you think about it. It's incredibly brave. There's no other situation I know, really, where people put themselves back into that traumatic position deliberately and re-traumatize themselves. And of course, for a number of women, they do have more than one miscarriage, and I think it's a hugely underestimated burden, I have to say. So I'm sorry I don't have data, but we will, we can go back and analyze the data, and I could try and come back to you on that. It'll take me a couple of months probably by the time I get around to it, but I can do that.
Well, I appreciate that, Tom. Thank you very much.
And our next speaker is Sophia. Sophia, sorry, I do apologise. If you're ready to make a wee start, I'll let you introduce yourself.
Yes, hello. Can everyone see me and hear me?
Yes.
Okay, so bear with me a second so that I just bring up here my slides, which were just here, and then somehow I was, sorry, here. Okay. So I'm just going to introduce myself. I'm a clinical psychologist and academic at Cardiff University. I am an expert in evidence-based fertility care. I'm not so much an expert in experiences of trauma. So my presentation today is going to center on existing evidence-based support during and particularly after fertility care, and kind of question if it's addressing trauma at all. So I'm just going to start by sharing my screen, if I may. Share. Can everyone see? So that's the topic of my talk today. And as I said, I'm going to focus in particular on the after treatment period, and in particular when treatment does not work. So it's unsuccessful and people have to move on and with an unfulfilled child wish. Now, just to say that I am quite aware of all kind of evidence-based fertility, psychosocial care that it's out there at the moment. And I can't identify one single evidence-based recommendation about how to address trauma within a fertility care context. I shared the European fertility guidelines sponsored by ESHRE. I'm quite aware of the advice that's national to the UK in the NICE guidelines, the support and advice that's available also via HAVA, and even out there with BICA. And from my experience, there is really no evidence-based recommendation on how to address trauma within fertility clinics. And these may be trauma as a result of fertility treatment, but maybe also previous trauma that people bring into that clinical context.
Well,
yes? Can I continue? Yes? I don't know.
Yes, I think I'd go ahead, Sophia.
Sorry. I also wanted to say that, the reality is that we have a lot of psychosocial support and evidence psychosocial support in the field. We have, of course, a strong presence of counselors in clinics. And you can see here that many of the interventions developed within the field are successful, and overall psychosocial care, it's very beneficial in helping patients face the challenges of treatment, managing the stress and the burden of treatment, but it doesn't specifically address experiences of care. Also at the start, the way we can kind of identify people that may face additional challenges and may need additional support during treatment, the kind of fertility specific tools that exist for screening do not address trauma, pre-existing trauma at all. Now, I think this focus on treatment within fertility care, it's recent, and I was very pleased to see that at ASRM this year, there was a workshop that was specifically about trauma-informed infertility care. And there is also now some literature starting to come out that's more practice-oriented or oriented. And now this literature that's coming out, it's not so much about how can we intervene with reproductive trauma, but it's more about how can we adapt our services for those people who already come into the services with trauma, and how can we change all the procedures that we have in order not to amplify that trauma or create compound traumatic experiences, which I think is extremely relevant also. And it's extremely positive that the field is starting to have these discussions. Now, a part of my work within fertility care has focused on the period after treatment, when treatment doesn't work. And my interest in this topic actually started when I chaired the European Fertility Guidelines. And when we reviewed all the existing evidence, our conclusion was that there were absolutely no evidence-based interventions out there to support people after these very significant loss. And there was some mostly descriptive evidence that tries to describe and quantify the impact of this loss, but it's still at a kind of emerging state. And as a result, there weren't really any kind of sound recommendations that we could do about how to support treatments after treatment, despite being so obvious that this is such an intense grief and loss that will have a lasting impact. So, of course, after seeing this, I focused on trying to really review this literature and in a systematic way. And we did a really broad literature review that focused on quantitative and qualitative studies to try to kind of measure the impact, but also understand how the people who go through this experience talk about it and what's their kind of personal experiences. And as I said, I'm not a trauma expert, but I've kind of revisited this data from a traumatic perspective. And it's quite easy to kind of start raising hypotheses about how the end of treatment can be a traumatic experience. And when I talk about this, I'm already ignoring the fact that during treatment there can be losses and perinatal loss, etc. And we already saw that those experiences are highly traumatic. So of course that will be, it just makes the scenario much more, the reality much more complex. But in a way, I'm also taking that a little bit outside of the equation in what I'm talking here. So some of the things that kind of the assumptions or that we make when we talk about the traumatic experience is that obviously it has to be physically or emotionally harmful. And there is a lot of evidence that we've kind of synthesized that really shows that the end of unsuccessful fertility treatment has a large negative impact on your mental health. So it creates disability, but also on kind of when we think about in more positive ways of your positive functioning in your health beyond the absence of disease, it also decreases your well-being. And this is now pretty well establishing. The other kind of important aspect to consider is, or if there's an assumption that the person has lived some kind of life-threatening experience. And of course, in this case, we are talking about the loss of potential, or as we just saw many times, actually real desired life. And I've put here the desired because people who go through fertility treatment are people who really have a very strong desire to have a child. So that desire plays a role in how loss is experienced. There's of course many other losses that come with this experience. There is the loss of this very central existential goal that most people have, which is to be parents and share their love and guide a new person through their life. There are threats also to the partnership, and Tom focused a little bit of that. And there is a lot of fear during treatment and immediately after treatment about how our partnership is going to now continue when one of the things that glue us together is no longer possible. But I have to say that within the fertility literature, the literature tends to be more positive and show that actually these kind of adverse experience of infertility and its treatment actually many times bring couples together, and that continues after treatment ends. And kind of population level studies did not show that there was a higher rate of divorce in people who go through treatment that doesn't work. Another important aspect is that people who go through this experience, they have to manage their loss, but they also have to manage the loss of those around them, because their parents want grandchildren, their siblings want nephews for their children to play at. So it's not a loss of your own, but it's a shared loss. And then the third aspect is of course, this experience will have many adverse effects, and my next slides will be about that. And so, as I said, one of the things that we did was also to do a synthesis of the qualitative research, and we wanted to see how this experience is from the eyes of those who lived it. And again, this is published, but what I did again was to review these narratives with a focus on what are common experiences in trauma. And so we talk about reliving the experience, and in this data, we don't see people talking about reliving it in the sense of re-experiencing it on flashbacks, but we do. People do talk a lot about re-experiencing grief as they progress through different life milestones. For instance, if your peers become grandparents, you even at an older age, you re-experience that grief again. And they also talk about the process of accepting the loss of not having the children that you want, not being linear, but being in steps where you progress through, and then you go back and re-experience the grief again, and then you progress a little bit more. And but there is this kind of feeling of it's not a linear trajectory, and many times you relive the grief. The other aspect is, of course, avoiding that threatening stimulus and the trauma, all kind of trauma associated stimulus. And we know that that is a common theme within fertility treatment. People avoiding the social interactions that are centered around children or where their loss is triggered. At the end of treatment, people really don't want to go back to the clinic where they were treated, and many times this also doesn't allow them to access the support that that clinic can offer. And also, there's some literature that shows that men tend to to cope by denying the loss and focusing on other aspects of their life. So avoiding is a very common theme. Another aspect is, of course, all kind of excessive arousal and negative mood and intrusive thoughts. And we know that a common theme at the end of treatment is anger towards everything and everyone. Of course, very extreme pain, sadness, emptiness, and of course, these are grief symptoms. But also a lot of guilt and self-blame, especially in women. Another very important aspect is that one of the central aspects for a positive adjustment is this need to make sense, is the need to process the event, and which is what is impaired in then trauma reactions. And people who go through the end of treatment talk a lot about a need to make sense of all their past efforts that they did during the treatment experience in order to achieve treatment. They also talk about the need to figure out who can they be now that they cannot have the children they wanted. And in a way, that almost means building a new identity. And as Tom highlighted so much, the context around can make that much harder, the type of language used, but also a lot of social preconceptions about what it means to be a woman, a man, and what families are, and etc. And they really talk about how they have to question all these worldviews. And these all kind of translates in a very in-depth re-evaluation of life values, so that they can then move forward towards, again, what can be a meaningful life. So this need to make sense, it's also extremely central to the experience. But as you can see, all these narratives overlap a lot with what we think are experiences of grief. And the end of fertility treatment has always been addressed from the grief kind of models or perspective, and not from a kind of more trauma-orientated perspective. Now, what we also know is that the adverse effects that we see are associated with the unfulfilled wish for children. So a research I've done with some colleagues in the Netherlands using population representative data, as you can see here in this graph, on the left, these two bars are people who went through failed fertility treatment but have children. And here, people who went through unsuccessful fertility treatment but don't have children. And as you can see, what seems to be associated with impaired mental health is not really the parental status, if the fact that you have or don't have children, but the fact that you still wish for children or more children. And as you can see in that group, on average, they score under the clinical threshold for where you can say that these people is likely to have a mental health disorder. But of course, what you can also see is that this suffering is higher when actually you don't have children. But what seems to be associated is this ongoing unresolved desire for more children. Now, this is very relevant because a few studies have tried to look at how this desire, if it is sustained, or actually if people can resolve it after finishing treatment. And of course, the assumption is that when you end treatment, everyone still has a desire for children when treatment doesn't work. And some research has shown that 3 to 5 years after treatment, half of the women in their sample still have this desire. 10 years after treatment, 1 in 4 women still have this desire. And our own study, which is the same study with the same data of this graph down here, show that the group here, these two gray bars, still represents 6% of women as far as 17 years after treatment. And this is highly consistent with other longitudinal studies that we have, that around 1 in 10 people never fully adjusts to the loss of ending unsuccessful fertility treatment. Now, I did try to find evidence that will allow me to think about this adjustment experience from a more trauma kind of oriented perspective, but I have to say that my search were very unfruitful. So there is, from my perspective, at the moment, very limited evidence that there is a higher risk for stress and trauma disorders after unsuccessful fertility treatment. Now, in 2015, some colleagues of ours did look at post-traumatic stress and post-traumatic stress disorder after different kind of reproductive losses, as you can see here, and they included a failed IVF in their systematic review. But as you can see, this is the number of studies that they included at the end. For any kind of these losses, you can see that the number of studies is quite small. So overall, this is really under researched. But what is very striking is that you can see there is no study focusing on the experience of trauma related symptoms after a failed IVF. Now, their findings are quite consistent with what Tom was presented before. Actually, in a way, their research kind of indicated that as time passes from your experiences, trauma symptomatology tends to decrease. But Tom results actually suggest that it doesn't decrease so quickly. What the research also showed that the longer the loss happens in terms of gestational age, the more likely it is that women will develop PTS or PTSD. Of course, these symptoms tend to be higher. That's what they found during the first weeks, but overall decrease over time for most, but not all. Although trauma results now seem to indicate that actually it's more long-lasting. And of course, as Tom also very clearly showed, women will report more symptoms than men. Now, as Tom also talked about, we don't know yet how having experiences of fertility treatment, and in particular failed fertility treatment, and in particular repetitive failed fertility treatment affects this experience. Now, a study, a Nordic study, did use also again a population representative sample to look at the incidence of different mental health disorders in people who did fertility treatment before and after treatment. They focus only on that group of people for whom the disorder is so impairing that they are hospitalized, and therefore the numbers that they report here are kind of low. But we know that only a small percentage of people who are actually affected by mental health disorders seek help, and even a much smaller percentage are hospitalized for it. So the number of the incidence in this group will be much higher. And overall, I just want to highlight, they didn't specifically look for PTSD, but they did look for adjustment disorders, which includes PTSD and stress disorder, trauma stress disorder. And what they found is that after treatment, the chances of developing these type of disorders are much higher, and you can see compared with the other kinds of disorders, shockingly higher. And their conclusions were that this disorder evolves typically in response to stress and grief, and it is therefore understandable among infertile females. The larger number of hospitalizations due to adjustment disorders after infertility treatments can be explained as a result of unsuccessful treatment, or also as a result of stressful childcare when treatment is successful, in particular if you have multiple births. But the results support that they result from the impact of stressful, unsuccessful treatments, and not from having multiple children. So there is a tiny little bit of research that suggests and indicates, at least in my view, that it's really worth exploring this further. I just wanted to also say that because there are no interventions out there, we did focus on developing support that people could access on their own outside of the clinics, because we know that it's difficult for them to go back. And we did develop a self-help intervention that's available online for everyone for free. And what this intervention does is that it takes people on a journey. It's based on acceptance and commitment therapy. So it tries to help people develop acceptance of the loss and helps them think about how they can then reorient their life, looking for new fulfilling goals, and try to rebuild their lives around these. There is nothing in this intervention that it's, again, trauma orientated. It came from the perspective, again, of grief, how you cope with grief and loss. It is tailored for unsuccessful, for building acceptance of an undesired child wish. And we did see that the intervention increases the well-being of people, people who use it after 10 weeks, and that this benefit effect is sustained at least for 6 months, which was our follow-up. And this was observed in the group of everyone who was randomized to the intervention, regardless of how they use the tool, My Journey. And you can see that the benefits are higher when we kind of focused on the people who used My Journey as we kind of suggest them to use it. So in terms of dose and frequency. But we also measured post-traumatic growth, which tries to capture really the kind of self-growth that can happen when people face resilience in their lives, such as trauma, but not only. And our intervention was not so successful in improving, in creating benefits in that sense. Now, there's some literature that suggests that this wouldn't happen as early as 6 months after, but our results at the moment do not seem to suggest that it's kind of happening at all. So it's just another illustration of how the support rebuilding is not kind of addressing, doesn't have any bespoke elements for kind of addressing trauma. Now, because of all these, we've tried, what we've realized from different strands of research is that fertility clinics and the fertility teams find it really hard to talk about patients, about negative outcomes in general, and in particular the possibility of treatment not working. And therefore, patients are really taken by surprise when this happened, and completely unprepared to deal with it. And that's according to their perspective. And so we have been trying to develop materials to support clinics in changing this norm and making conversations about the possibility of treatment not working more frequent and normalizing those conversations. And so we've developed different kinds of materials, both directed at patients who want to explore these on their own, but also on clinics on how to empower them to have these conversations. Because it's our deep feeling that patients need to be prepared in advance for the possibility of treatment not working. We also need to identify at the end of treatment those who may be at risk to develop not to be able to cope with it, and also to develop a support portfolio of which my journey was kind of the start, that people can access when they leave the fertility healthcare context. And therefore, we think it's important to develop more self-help evidence-based tools, but to link with charities and other support institutions at this moment, it's also very important. Also, extremely important in our view is that there needs to be much more awareness in primary care and in general about the impact of an unfulfilled child wish on mental health. And this is regardless of the types of loss that we experience, more or less traumatic, before you're faced with the definitive reality that you won't be able to have the children that you want. And in all kind of all kind of healthcare professionals coping, working within the mental health services, they need to start asking about parental status and particularly desire for children when they discuss mental health difficulties, and particularly with women, I would say, but not only. I just wanted to finish with, because I was asked a little bit also to do this, about what is needed to look at trauma within fertility care. And really, this is what I have here is what we would say for any kind of phenomenon when we want to approach them from a research perspective. We first need to estimate the problem. We have no idea what is the percentage of people who come into fertility clinics already experiencing trauma, but also who may develop PTSD as a consequence of the treatment itself. And I'm not talking about losses that may result from the treatment. We need then to have a more kind of understanding about what makes people more vulnerable to have traumatic reactions, and in particular these compound effects of reproductive trauma, just multiple reproductive trauma, but also reproductive trauma combined with other kinds of trauma. And if we think about then starting to address these, the best way to start is really to review all kind of trauma-informed healthcare interventions from other areas that maybe we can consider in translating to fertility care and reflecting on how suitable they are, and then probably also develop and evaluate interventions that are bespoke to the specificities of fertility care. But of course, we can start from the work that's already out there. And also, in particular, I think this interface between fertility care and mental health care pathways and other pathways to deal with trauma within reproductive care also need to be examined and improved. And I would stop here. Thanks for your attention.
Sophia, thank you very much. Very, very interesting presentation. Certainly in my clinical work, I'll be thinking of some of those questions. We have 5 minutes for questions for either of our last two presenters. So I'm sorry, just trying to keep ourselves on time. So there's so many questions I would have, but I'll obviously put it out to yourselves. So for either Tom or Sophia, please shout or put it into the chat.
There's a question here. Sophia, did you find any qualitative case reports when you were doing your review? So yes, as I said, it was a systematic review of all the quantitative and qualitative research out there. There is a lot of research on, adjustment to unsuccessful fertility treatment. And people do talk about, this as a traumatic experience sometimes, but what mostly came out was more of a grief reaction and the loss reaction. But of course, these also happened in the context of their fertility pathway and or their infertility pathway and the fertility care they received, and how much of aspects of that could be traumatic. And one important aspect for adjustment after is this sensation of having been well advised during their treatment pathway, and being able to kind of have control over the decision to end treatment, and that this is not taken out of their hands, or that it's just because they can't access treatment, or because there are other health complications that make treatment harder, etc.
Was really lovely. Thank you. Thank you very much.
I am furious, at home, alone and at work. I can't handle the pressure anymore. The commute makes me tired. Most of the time I hate my job. All day I just want to sleep. Why can't we have a baby? I hate IVF. I'm at breaking point. I may have already broken.
I may have already broken. My body hates me. Why doesn't it work? I want a new challenge, but we're being held back by IVF. Everyone hates me because I'm so tired. I'm losing all respect as a manager because I just want to sleep. Nothing is easy for me. I want to leave my job.
I don't want to leave my job. I feel so vulnerable. What if our marriage is broken? I want to hide away from the world, just sleep. I can't sleep. I can't eat. It doesn't work. I look sad. I am sad. I slur my words, feel sick and tired. No one understands how this makes me feel, this IVF.
Will we ever get there with the IVF? No one would understand if I took time away from my job. My neck and shoulders hurt. This headache makes me so tired. I'm only 37. I shouldn't feel this broken. It's not fair that I should lose the respect I've gained at work. I'm tense. My teeth hurt. Please let me sleep.
Does life even matter as much as sleep? I'm anxious about my health, how it's affected by IVF. I'm scared about a pregnancy, let alone work. Will everyone hate me if I take a break from my job? I may have already broken. I'm exhausted, negative, irritable, tired.
When will all this end? When will I stop being so tired? When will I be able to sleep? When will I stop feeling so ashamed and broken? I blame my routine, but it's not. It's the IVF. I can't concentrate enough to do a good job. I need someone to understand. Why doesn't anyone talk to me at work?
Tired of people. I want to be me again, not embarrassed to talk about IVF. Sleep is not support, or health, or hiding the pretense I show in my job. Broken all communication. Please help. My smile really needs to work.
My name's Gerry McLaughlin. Yeah, I'm a senior lecturer at Queen's there in the School of Nursing Midwifery. And as Hilary said, myself and Ian and Hilary and all the people had this conversation, and slowly we've come to here today, which has been really, as far as I'm concerned, amazing. So I'm just wanting to focus on this thing called EMDR. It's been mentioned a few times. So and I'm an EMDR European consultant. So hopefully I know a wee bit about it. We had our Ulster, EMDR Ulster annual conference, and it was opened by the EMDR President of Ireland, All Ireland, Gus Murray. And I was very struck with his first statement to the conference was, you cannot talk your way out of trauma. You cannot talk your way out of trauma. And I'm going to explain that. And certainly the slides and the presentations that went earlier have actually backed that up very, very clearly. So I think if we're caught early, we can. And it's funny, the Tetris come up there because I'm also involved in a PhD about, again, the neonatal intensive care unit and parents. And we know that parents really do suffer a lot of PTSD through that experience. And exactly what we're starting now is about the prevention, and we're going to compare Tetris to a modified form of EMDR to see if we can prevent parents developing PTSD. So we'll see what comes out of that in due course. We're hardwired for safety, which is wonderful. So we've got this sympathetic nervous system that keeps us safe. You're about to sit in front of a bus, bounces us back. But when the life we're living throws lots of other things at us, like fertility, there can be major, or infertility, should I say, there can be major problems with the system that is inbuilt to help us keep us safe when these conditions are ongoing, recurring, and things like that. So what does trauma actually look like? Well, there was a study done by Lanius and was published in 2003. And there's a husband and wife. So these two poor people had been through a horrific road traffic collision. And as you can see, they conducted an MRI scan as they had to read the experiences of what they went through. And noticing this, most of us are visual learners, so seeing this, the husband's brain is lit up. So the lighter the color, the higher the color, the brighter the color, the more activity. And you can see his brain is lit up pretty well as he's going through this recalling this awful experience. But his wife, his brain looks very, very different. And I'm sure you can see this as well as I can. It's essentially the vast majority of her brain is in neutral, if you want. It's been shut down except for back here. And I'm no neurologist, but I've been assured this is the visual cortex. And that's back to Gus Murray's, it sits too far back and too deep in the brain. So when I often ask students, you know, what do you think of this? And at first people have sometimes said, oh, obviously this man's much more traumatized than this woman. Look at the way his brain's lit up. That's the way his brain should be. He's actually more advanced. If you want, he's further on in his journey of recovery than this poor woman. So he remembers being in the car and how difficult it was. She's in the car. And it's almost like he remembers being in the room with the lion. She's in the room with the lion. And this isn't going to go anywhere. And quite clearly, the data is showing that it's significant. I was really shocked. 20% of women, and who knows what it is for men, go on long-term to hold this. And absolutely right. We know that post-traumatic stress disorder, or shell shock, as we used to call it, it was at a time very, very untreatable. And people spent decades in asylums, in psychiatric hospitals, or suffered grievously, and unfortunately, yes, some did take their lives without doubt. So I think that this visual, this is a beautiful study, and but to see this very clearly, so this is what trauma looks like and its impact on the brain. And I would also say we can do that for the body. We often talk about two types of trauma: silent trauma and loud trauma. Silent trauma is things like abuse and rape. And we see levels of PTSD much higher than the loud trauma. And loud trauma is what we call road traffic collisions, earthquakes, those type of things. Anybody, any ideas why that might be? Why that silent trauma? And again, though that word was silent was mentioned earlier on in one of the presenters. I think that idea of well, I'm not going to say anything that I'm pregnant yet until 12 weeks. And unfortunately, then maybe you lose the child. So I would see that as silent trauma because others haven't been told. Why might that be? Why? Anyone, any ideas? I can't see the chat, if anybody wants to chip in. Any ideas why it might be that silent trauma is worse or seems to have a much higher rates of PTSD?
Self-preservation.
Is it that it's unrecognized?
Self-preservation, not recognized. Absolutely. We're as biopsychosocial, spiritual being, so we're a social being. We talk to other human beings. And when people don't know that what you're going through, or it's been kept quiet, then they can't engage with us. So before it sets in, and in those early days, if we're able to talk and share and be, you know, have other human beings around us, that is very, very helpful. So when you had a road traffic collision, when there's been a major earthquake or a major event, people are talking and sharing and supporting. But when it's silent, like abuse, rape, or the loss of a child, or that fertility journey, then that potentially leaves you isolated and leaves you alone and much more likely to experience emotional difficulties rather than heal and grow. So is trauma and PTSD important? Myself and Ian supervised a girl, Yasmin, back in 2019. So Yasmin was a nurse working at nursing homes and had noticed people who had developed dementia had a previous history of PTSD, untreated PTSD. And she wondered, is there a link? So as has already been said, Northern Ireland has the highest recorded rates of PTSD on the planet. I think Marlene's point, you know, wanting us to work with other people about these type of things would make a lot of sense because of the troubles. So we have very high levels of PTSD. So Yasmin wanted to look at this, and for her master's thesis. So she was fluent in English, Spanish, and Portuguese. So myself and Ian supervised her, and she worked very hard. And she read lots and lots of international publications on PTSD and the links to dementia. And in March of that year, there was something like 10 international papers published on this link. Is there a link? And she discovered that 60% of published papers in English, Spanish, and Portuguese said there was a link between PTSD and dementia. Therefore, 40% said there wasn't. But we know with the research hat on that actually you have to go with the weight of evidence. So the published international publications and all those high profile and high impact journals were saying there is a link. What they are, they couldn't be sure. Personally, my opinion is it relates to sleep. We see a lot of sleep disturbance from people who are very traumatized, and sleep is very important to look after the brain health. And typically then when people are suffering these experiences, they go off to their GP first or some type of prescriber, and often are prescribed SSRIs. And SSRIs can be very difficult and not helpful to sleep patterns. So it's interesting to see. So today, for me, saying that maybe 20% of women who have had a failed pregnancy in some ways, or all these hidden issues that I'm unaware of, could be developing PTSD. Well, they also then could be setting these poor souls up for dementia in the future. So where did EMDR come from? So Francine Shapiro was the woman who stumbled upon it. She was ill with cancer and with breast cancer. This is back in the 1980s, and working in University of New York. And one lunch break went out for a walk to think about her cancer. When she returned the next day, thought nothing of it, but the next day went out again for a walk and discovered herself not as distressed as the day before. And she thought, well, how come, you know, I haven't had some type of breakthrough. There's no new drug, there's no new treatment that I'm aware of. How come yesterday I was going up the walls, but today I am quite calm about this? What's this all about? So she remembered, she was thinking about the walk yesterday, and she vaguely remembered her eyes going back and forward really quickly as she was thinking about this, just doing it by itself. She thought, this is odd. So she went back to her office, and there was a colleague there, Popke, and she said to him, right, this has happened to me. I want you to think about something that's really upsetting you and move your eyes back and forward really quick. And he said, I can't do that. I'm a man. Leave me alone. So she said, right, bring it up and just follow my fingers. So she started moving her fingers back and forward very quickly in front of his face, and he had to follow them with his eyes, keeping his head still. And she discovered that, yeah, it was the same for him. So she actually asked her to do a PhD. Now, today, if you walked into any university, certainly Queen's U or anywhere else, and you said, this has happened to me and it's happened to a friend of mine, can we do a PhD, please? You'd be told to jump out the nearest window and behave yourself. She was working in a university. At that stage, she was now into psychology. It originally started into in English literature. And hey, presto, she did her PhD. Very quickly into that PhD, somebody came along who was blinded. So they thought, right, well, we can't move our fingers back and forward across somebody's face. Tell you what we'll do. And it was this idea of tapping the back of their hands or clicks at the side of their ears. So we now call those bilaterals. And she actually found it worked. But this did not go down well because PTSD, and she just chose PTSD, was very, very difficult to treat. The theory goes also that she was female, had come late into psychology, and she's also Jewish. So there's a lot of studies followed that was going to disprove that EMDR is anyway helpful. The arguments were it's nothing more than CBT with eye movements. But as they did more and more studies, people found it did work. And she also found very quickly that in some of these studies looking at these eye movements, or these taps and these clicks, are incredibly relaxing. And I had that image of the being hardwired. So actually, we've got the sympathetic nervous system, as we all know, the fight, flight, freeze, or flop. And then we've got the parasympathetic, the braking system. And these bilaterals are incredibly relaxing. So the research has been there, and is now well established in relation to post-traumatic stress disorder. The World Health Organization 2013 said, yeah, it works. And it works particularly well. It's great that it can work with children. It can certainly work with adults. There's not a lot of reading. In fact, we now have approaches where you don't even have to tell me what it is that is disturbing you. We give it a neutral term. We call it pen, we call it watch, we call it phone, whatever. NICE have endorsed it as well, although their study, their publication 2018 would say you must first of all try CBT with a trauma focus, and if that doesn't work, then you try EMDR. However, they do allow for your own choice. And then the International Society for Trauma and Stress Studies in 2020, September 2020, published, and that is a huge organization, very big names in it, more or less looking at the same literature that NICE had looked at. And what they said, there's 3 interventions that we know work for PTSD and that they're research and evidence-based. And 2 of them are EMDR with a trauma focus, or EMDR and CBT with a trauma focus. There's another one in relation to cognition, cognitive work. They did not give them any hierarchy. They said they all work. And there's others out there too. So increasingly, we're seeing a body of work emerging in relation to EMDR, in relation to psychosis, self-harm and depression. So at the minute, the evidence is very clear in relation to post-traumatic stress disorder, and it's emerging in these other areas. We eventually think it probably will be what we call transdiagnostic. I personally have used it with people with blocked grief, OCD, and all these different I suppose it's how you look at someone and how, and I would explain things to them, and they will make decisions on whether they want to try this or not. So as I said, they originally began with eye movements, now we speak of bilaterals. So I can either tap the back of your hands, we can click, we can have buzzers, and I've done it online where people have either followed my finger as it moves across the screen, or they have done their taps on their shoulders. So what is this thing called EMDR? This is the Council of Scholars. So it's a big, it's a collection of international scholars. Francine Shapiro sadly died back in, I think it was 2021. And it was to kind of continue her legacy. So now we would say eye movement desensitization reprocessing therapy is an integrative, client-centered approach that treats problems of daily living that are based on disturbing life experiences that continue to have a negative impact on a person. So here we're moving away from those kind of trauma, those kind of war, and high-level trauma. These are work on the problems of daily living. Its adaptive information processing theory hypothesizes that current difficulties are caused by these difficult memories that are inadequately processed, and the symptoms are reduced or eliminated altogether when these memories are processed to resolution using dual attention bilateral stimulation. So the person is looking or bringing up this disturbing memory from their past while these bilaterals are going at the same time. So it's almost we're hitting the accelerator and hitting the brake at the same time. These targeted memories, once resolved, are hypothesized to result in memory reconsolidation. So we see people who it doesn't feel like a memory, that this happened 20 years ago, but they can give it to you in great detail and color and things like this. That seems really strange. But when we do the EMDR, all of a sudden they remember it as a memory of 20 years ago without that level of clarity and the heat, if you want to take it out of it. The standard application of EMDR therapy is comprised of 8 phases and 3-pronged approaches. Memories of past adverse life experiences that underlie present problems, present-day situations, and anticipatory future scenarios. As I said, there is strong empirical evidence for its use in the treatment of post-traumatic stress disorder, and has been found to be an effective treatment for a wide range of diagnoses in a variety of contexts. But the research base for these is emerging. So this AIP, and this was postulated by Francine Shapiro, adaptive information processing. So basically what she's saying is our brain, our body wants to always have homeostasis. The material comes in, that it comes up through the brain and is metabolized, is digested, is processed into a natural. So when ordinary things happen to us, off it goes. But when difficult things happen to us, and this is the theory, and obviously it hits the amygdala, and that's the alarm system for the brain, this isn't safe anymore. This isn't safe anymore. This material is very, very challenging, is very traumatic, isn't safe material. So it's safe or not safe. This isn't safe. And these are theories that therefore digestion or how the memory is laid down is interrupted by this. And EMDR, we believe, helps to get us over this and helps to allow this adaptive information processing to return. So I had a young girl the other day, and she was telling me of an event happened when she was 3. So it was over 20 years ago, and she was able to explain to me in great detail and the color of what clothes that people were wearing, what they were wearing. It was uncanny. And within like 15, 20 minutes of EMDR, she said, I know it happened, but I haven't got that detail anymore, and it doesn't bother me at all. So we become what we were told mental health midwives. So the trauma disrupts this information natural processing. EMDR reboots this natural system in consciousness and allows Mother Nature to do a job, just like a midwife. The midwife does not give birth to the child. She facilitates, or he facilitates, a natural process, and that if all goes well, fantastic. If there's difficulties, the midwife intervenes, and maybe other members of the maternity team intervene to assist this woman to a natural delivery or a healthy delivery. And for us too, in mental health, then, when someone is disturbed and distressed by these previous life events, and really they are stuck almost back in time with different triggers producing very, very distressing symptoms for them, EMDR can get this moving again and help us over this massive hurdle, and then we can move on and be happier and healthier. So when there's a road traffic collision, not a road traffic collision, there's a pineapple. And again, I had a taxi driver came to see me. He had a very bad accident one Christmas where a drunk driver came into him at a major roundabout here in Belfast. And he had no memory of what happened after the accident. I thought maybe he knocked unconscious, but he found it like very, very difficult, almost at the point of losing his marriage, his job, and was really struggling. So off we go and do this EMDR. So he tells me all about this, and I said, tell me what you've seen. And he was able to tell me in great detail about this accident scene, about there's a red BMW 1 Series over there, there's a guy driving and a girl beside her. And he started giving me the detail of this accident, and it was like uncanny 3 years beforehand. Strange. So he started into this, and he chose to have taps. So I was tapping the back of his hands, and I'm asking him to think about this accident in great detail. And on we go. So 30 to 40 seconds later, I stopped and I said, well, what's happening now? And I said, Derek, the only way I can explain it is if I swallowed a pineapple and it's sitting in my chest. And I said, go with that. So we do another set. We call another set, another 30 to 40 seconds of taps. What have you got now? And he says, a melon. So a melon's roughly the size of a pineapple, but is smooth without all those spikes. Okay, another 30 to 40 seconds of taps. What have you got now? So I haven't reframed anything. These sensations are real for him in his body. EMDR is very good at clearing the body. And he said, I've got a grapefruit. And we went down the fruit aisle in Tesco, Asda, or wherever you shop. So we went from pineapple to melon to grapefruit to orange to apple to pear or to plum to grape, as I remember. And all of a sudden, there was nothing. So I said, now tell me about this road traffic accident now. And not say his exact words, but it was colourful. And he says, what have you done to me? He said, I know it happened, but I can't see it anymore. And all of a sudden, then he could remember the emergency services arriving, cutting him out of the car, the snow falling, and go back into the ambulance and go into the Royal. And to my mind, it's almost standing in front of Mount Everest. All you can see is Mount Everest. You can't see what's behind it until it crumbles. So he could see the accident and all this impact, and all the memory that we thought was missing was all there, but just laid down. So that worked in the space of probably 20 minutes. Went from his subjective units of distress about this accident being at 10, couldn't be any worse, to being it was gone. And it was a thing in the past that he could remember. When we started, he said, it's just sitting there. It's just sitting on the edge of my eye. If I look over, and obviously as he's driving along, you can see the same type of car, the colour of the car, and different things, all these different triggers to bring it back. So before I finish, I'm just going to do just a little thing for safe, calm place in the butterfly hug. So this is part of when we're working with the EMDR, we call it stabilization. So safe, calm place isn't anything. I mean, it belongs in lots of places. So if you can think for me of a safe, calm place for you, it could be somewhere from your past or in the present. And it's just somewhere which feels safe and calm for you. So it could be a holiday home, it could be your front living room, it could be wherever. One person told me my car. He was a real petrol head and just loved driving his car. So I want you to do, I don't know if you can see me or not, is just cross your arms over your chest like this, or put them on your knees or wherever. But what we do is we tap back and forward. So it's not together, but it's back and forward, back and forward. So I just want you to think of a safe, calm place for me and just do some taps. We're going to do this for about 30 to 40 seconds. And hopefully you will feel the benefits of this, because to the body is a biological machine. When we press certain buttons, it does certain things. So when we just tap like this, our body will start relaxing. We found with these bilaterals that your blood pressure reduces, your pulse reduces, and other biological features of relaxation. So it's this parasympathetic, parachute slows down. This parasympathetic tone is increased by bilateral stimulation. My wife's a primary school teacher. She does this with P1s. She finished her master's in education, and she used the butterfly hug in the safe, calm place and compared it to other interventions in a classroom setting and got great results. So it's incredibly easy to learn, incredibly easy to do, and it just relaxes people beautifully.